So again, officially, welcome and thank you very much for coming to this commission. We have Dr. Daniel Elkeles and Ms. Merav Dover, who both have played a very significant role in really driving integration of care, which is one of the areas that we are very, very strongly committed to in this commission. And really, we want to find out how you've done it. And what are the obstacles, what are the enablers, and ultimately we're looking for accelerated solutions. You know, we've had enough of pilots that work. We want a system-wide, London-wide transformation of care. Integration is a very important part of that. So any thoughts would be much, much appreciated.
Okay, so
briefly,
I'm going to kick off.
Yeah.
I have to confess I'm not a doctor, but my dad is. So I'm representing...
That's better.
Yeah. So I'm representing Shaping a Healthier Future, which is the largest hospital and out-of-hospital reconfiguration programme in the country. And I hope in what I say in the next couple of minutes, it does try and bring together everything you've heard from all the witnesses you heard this morning. So it's a partnership of 29 health and care commissioners and providers across North West London. The programme is entirely clinically led with all the provider medical directors and all the CCG chairs on the board. And almost, I'm going to say almost exactly what Stephen Dorrell said to you first thing this morning. Our strategy is about centralising services where there's good evidence to do so, and then localising everything else, and with all health and care being integrated. We're planning to move from a hospital-based system to where the majority of funding is spent in community and home care settings. So I thought I'd spend a little time on hospitals and then most time on out of hospitals. So for hospitals, North West London will end up with 5 major hospitals, each with the capacity and the patient volumes that enable them to deliver all the key quality standards that have been set out in the past. And then we'll have 3 new hospitals, one in Ealing, one in Central Middlesex, and one at Charing Cross. The Central Middlesex one will focus on orthopaedics. The Charing Cross one will focus on ambulatory cancer centre and 23-hour elective surgery. Each of these 3 hospitals will have about 100 rehabilitation beds. So I think we have a slightly different approach to Professor Rudd, and we really are focusing on that you can do a lot in rehabilitation in specialist centres. And all of the 8 hospitals will be the hubs for the integrated care strategy for the local borough that they serve. On out-of-hospital care, we're planning an investment of £190 million of new money in out-of-hospital care services in the next 5 years. This was the first year, and we have made substantial investment. At the centre of our out-of-hospital plan is our whole systems integrated care plan. And that starts with integrating health and social care commissioners. And when you've integrated them as commissioners, the plan is threefold: to increase the consistency of primary care, both in quality and access, then enabling GPs to work together in localities to deliver an enhanced range of services, and then for these locality networks to form multidisciplinary partnerships or joint ventures with all the other providers of care in the area to transform the care for particular patient groups who would benefit most from integrated care. And we spent a long time thinking about which are the patient groups. We've identified 9 of them, most of which you've heard about this morning. So the elderly, people with long-term conditions, people with cancer, people with mental health issues. And by doing this, we think we can improve patient satisfaction hugely and reduce hospital beds by 20%. To do it, you need a complete rethink about how most aspects of care are delivered. And just for Andy, please note I haven't said the answer is an ACO. In terms of our integration work nationally, we've got 3 asks. One is the payment systems that support user-generated outcomes. Secondly, information governance that encourages integration. And thirdly, organisational development and education that focuses on self-care and breaking down the barriers between professionals. And this is a particular challenge we're finding most hard to get traction on so far, because it requires a huge amount of retraining and different ways of training staff. And then some asks for you from the London Healthcare Commission. So firstly, talking up community and home care as the answer to where healthcare should be provided. So lots of photo opportunities of Boris in community services, people's homes and GP practices. Political support, or at least neutrality, for clinically led and supported service change. Supporting education and R&D initiatives that focus on delivering out-of-hospital services. On transport, we've done lots of good work with Transport for London, but there's lots more one could do, and there's a lot you can do with joining up NHS and local authority transport provision. In housing, there's a lot we can do to develop extra care, so where people can live in appropriate accommodation where we can easily provide healthcare support to them. And lastly, on planning rules that give priority for health and community hubs and support capital coming in from developers when they're doing new work. So those are my starting thoughts.
Thank you. Thank you. Merav, do you share those views?
Yes, certainly. And perhaps if I can just add a bit about the ways in which we're going about integrated care and some further thoughts about perhaps what you as a commission could do to support us. Firstly, if I could just say that I believe the Commission starts from a very good platform. Indeed, Lord Darzi, your framework for action in 2007, and certainly since then in Southwark and Lambeth, where I work, we've reduced avoidable deaths, albeit there's still much more to do to reduce deaths in heart disease, strokes, cancer and respiratory conditions. London's interesting though, because of course London has a reputation for world-class, high-end, innovative health treatments. I'm the Chief Officer across Southwark and Lambeth Integrated Care. That's across health and social care. Our health partners are part of one of 6 academic health science centres. And we've been given that designation because of the world-class research, health education and delivery. But what aren't we world-class in? We're not world-class in delivering cutting-edge, proactive, preventative care so that people get the right care in the right place at the right time. Only receiving care in an institution, say a hospital or a care home, when appropriate. So that's what we're about. My hypothesis is if we can do that really high-end stuff, we really should be able to get the right care in the right place at the right time. A little bit about where we are and what we're doing. So local people tell us time and time again that our care is fragmented, it's reactive, and it's unreliable. In Dr. Thomas Lee's words, they're scared of the chaos. I think it scares our professionals as well as scaring the people who are at the receiving end of it. So the leaders of our local care system, remember this is health and social care, have come together with citizens to push ahead on 2 things. One is to make improvements within the current system, and secondly, to transform the system, to shed it of its chaos. And it's that transformation of the system that I want to talk to you about, the ways in which we're doing that and how I think you could support us. So we're doing 4 things essentially. The first is we're developing the assets in our community. We're working with communities to support self-management, such as management of weight, of alcohol, of smoking, of blood sugar. And we will be developing an ever more extensive network of volunteers, being really mindful of the personal and social benefits to the volunteers themselves, not just the people whom they are helping. So that's the assets in the community. Secondly, payment systems, as Daniel spoke about. We must create integrated physical and mental health and social care payment systems. These must focus on achieving the outcomes that matter to our citizens within the available resources. And these payment systems are, of course, then going to incentivise, for example, prevention. So prevention of falls. The payment system currently incentivises the treatment in a hospital to fix someone's hip. It does not incentivise that the many people who go into somebody's home notices the frayed carpet and gets the carpet fixed. We must, as we've heard, transform our model of care and our workforce, and that's what we're doing, and that includes general practice, outpatients, care in the home. as Stephen Dorrell was saying, that's how we'll demonstrate to our communities that actually they can be confident in what's happening in the community. The workforce, of course, will have to work proactively and preventatively and have a very different relationships with citizens to support their well-being. And fourthly, informatics. So, as has been said many times today already, we need informatics that enable measurement. It needs to enable real-time sharing of information between professionals and between citizens. And it needs to contribute to research and development. We have already in South London and Morsey My Health Locker, which is just a really nice example of enabling people to manage their own care. Okay. But let me move on to how the Commission can support us.
Yeah, we're right. We want to talk to you as well.
Okay.
Yeah.
So just really quickly, my suggestion is we have something like, we should work together on something like Get London Caring. So we've got Get London Reading. It's a standard initiative supported by the Mayor. The proposition is really simple, it's effective. Volunteer today, support each other today, and change lives. So you could help us by catalysing our work to increase volunteering at scale. You could, through this commission and through this Get London Caring, use the evidence of behaviour change so that people get self-management and start to do it. We don't need more information about losing weight, but we need to understand and get people understanding how to do this better. You could focus on making working in the community more attractive, and as Daniel was saying, some of the most important care takes place in people's homes, and yet that's precisely where we can't recruit people to. So whether you do it, as Daniel was saying, through photo opportunities, whether it's prizes for our unsung heroes, I think we can learn from Teach First to attract some of our most able people.
Thank you.
Secondly, we'd really like you to set up some kind of innovation zone that deploys disciplined innovation methods to support us in the kind of testing that we need to do, and one that will really make us able to make us move further and faster by helping us diffuse the learning, for example, that Daniel's having now and that I'm having, and that really moves across London at pace.
Great, thank you. Thank you very much for that. And I'm sure, could we have those notes you've done? So we'll include them as part of our evidence. So, any questions?
Yeah, I'd like to start where you finished, really, about getting the message across, because a number of the speakers earlier on were saying current structures are a problem. In fact, I think one even said throw out the current structures and let's have a whole new change again. Whereas you seem to be working within the current structures, albeit it's not perfect. So how do we get that message across to others that, hey, you can do it?
By doing it. So bizarrely, I think we have unleashed the most incredible change. So having, in hospitals, the best hospitals are always the ones where clinicians come to the fore and lead. And now we have in commissioning the ability for clinicians to come to the fore and lead in commissioning, in clinical commissioning groups. So yes, it is fragmented because there are 32 of them to reflect the boroughs, but the power that you have at a borough level with the GPs and the councillors working together is huge. To make change.
Which is presumably your health and wellbeing boards, so where do they fit in?
So they're key drivers of change. I mean, there's a huge development journey to go on, because you've got to get them to be an equal, where health and social care play together jointly. It's not just another overview and scrutiny committee where it's performance management. It's all about how do you work together to get the system to provide good health and social care for the residents of each borough.
But through London Councils, and I'm the lead for health on London Councils, we set up a network of health and wellbeing board chairmen, and there is a vast difference of opinion about the power and the capabilities of those health and wellbeing boards. So how can we package your stories and send that on?
So we're using the Better Care Fund to do that in North West London. So you're putting essentially at the disposal tens of millions of pounds of jointly funded health and social care, and you need the right governance mechanism for it. If you constitute the Health and Wellbeing Board right, it's a ready-made governance vehicle.
Thank you.
Andy.
I think what you're both doing is hugely exciting, actually, and I think there's a lot to be learned across London from the model of care that you're developing, because really you're creating a virtual organisation in a sense that's actually looking at these risk-stratified long-term conditions in the community, but presumably it's the CCGs who are accountable at the moment for delivering the outcomes. Is that right? In which case, what about, what's the incentive for the providers to remain engaged in this process? Because there are so many perverse incentives in the system that, for example, that, they're incentivized, as you say, to look after the fractured femur and repair it as rapidly as possible, but they're not incentivized to actually adopt any kind of preventive approach to it. So is there a further step you can take in enhancing the accountability here?
We're actually not finding that a problem. I think it's possibly slightly different for us because we don't have small DGHs who feel that they're personally at risk through this kind of change. They're absolutely incentivised by providing the right care in the right place at the right time, which they know is not in the hospitals. I think what will make it right is that the health and social care together will define what outcomes and with citizens. They'll define the payment systems, and then the providers with a new workforce will be accountable for delivering those outcomes. So there's two things we have to do in parallel and quickly. One is get the payment systems right to incentivise the right behaviours, and the other is to absolutely transform our workforce and the workforce that's working in the community, including general practice.
And it is early days in terms of this pilot, and you started off with a population of diabetic patients. Have you made any demonstrable gains or improvements in outcomes so far? And this is North West London in particular, Daniel.
So I think all the evidence is huge, actually, that we have. So someone mentioned earlier about dementia diagnosis. So one of the things we focused on in the multidisciplinary teams in the elderly was let's sort out dementia diagnosis, and we have a massive increase in diagnosis of dementia. Next problem is what services do you put in place, having now actually identified all the patients? Gets you into lots of complex questions about things like memory clinics, and how do you take them from being a specialist service into actually lots of clinicians can do memory clinics, because otherwise you can't provide the service. But just going back to your question about how to incentivise providers, for most of the providers, I don't think it's very difficult to incentivise them. You get groups of clinicians together and you say, what is the right care to provide for patients? And most clinicians get there very quickly and then are champing at the bit to do it. It's the hospitals you have to incentivise, you have to get right in the incentive. And very crudely, we think hospitals do two things. There's about half a hospital which focuses on prevention, which is outpatients and diagnostics. And the other half of the hospital focuses on dealing with really sick people. And the way you incentivise the half of the hospital that deals with the sick people is you enable the clinicians to work together in sufficient critical mass with the right buildings for them to do things like you've demonstrated with stroke care. And so that's about investment in critical mass, and then that drives that part of clinical behaviour. And then for the office-based consultants, the ologists, you need them to be working the multidisciplinary teams with the GPs, social care and community and mental health. And that does require rethinking payment by results. It requires forming joint ventures that actually do have capitated budgets that incentivise delivery of out-of-hospital care. And I think we're on the verge of, in North West London, being able to do that in the next financial year.
Okay. Thank you.
I think one of the key challenges, of course, is getting everything joined up, which you've been working very effectively at. The second challenge is to demonstrate that getting everybody joined up actually delivers an output, and the key to that, in fact, is I think, as Merav has said, it's informatics. And it just seems to me that when you look around the world at the places that do all of this right, it's always anchored in that one word, that they have an informatics system that allows them to know what they're doing and allows them to know that they are doing something right at the end of the day. So that's a real challenge here, isn't it? Because we've got lots of different systems. They're starting to integrate and starting to join up. But even within the hospital system, we don't have the sorts of informatics that we need to do to make things work. So perhaps could you give us some thoughts about how you see this working across a range of clinical commissioning groups, across the various parts of London that you represent, and how those parts can talk to each other, for example?
Well, if I just say a few words, and I think Daniel wanted to come in. So we have to get the connectivity right. We have to learn why MP Fit wasn't so successful. And I think it's around getting the connectivity between different systems, not saying we'll go just for one system. I think you're absolutely right that this has to be at least London-wide, the connectivity, because we have highly mobile, our citizens are highly mobile and use many different services in many different places in London. So it's not, for me, it's not just about getting that connectivity across health and social care. We know we need to invest in that. Actually, one of the really difficult bits is there are now on the market lots of different ways in doing it. If you're impressionable like I am, every time I meet a provider who's selling me some bit of kit, I'll say, oh, yes, we'll have one of those. I think we need a very sophisticated conversation and process that actually comes to conclusion about how we are going to do this connectivity.
So I would add to say, so there are two massive enablers of out-of-hospital care. One is having some good buildings, and the other is IT. So I'm Chief Officer of 5 clinical commissioning groups, and in the last year, each of the clinical commissioning groups has had a vote to say we should move all the GPs in the borough onto the same IT platform. Interestingly, all 5 boroughs have chosen the same IT platform, so by the autumn, we'll have 250 practices all working on the same web-based IT platform. That is a game changer, because not only does that mean the patients can have a handheld app of their GP medical record, we've already got the community nurses in Hammersmith now using the GP's IT system. We've got that IT system is in the A&E department at West Middlesex and in their medical assessment unit. Every service we are now commissioning, we're saying, if it's based in the community, you have to use the GP's IT platform. You get an integrated medical record that patients can see, real-time information. Actually, you didn't need a national system to do that. All you've now got to invest in is the interoperability between that system and the bits of a hospital that you'd never want to run on a GP platform, or the bits of mental health that you couldn't because their function is too different. So I think you can solve the IT problem within 2 years across London, and it doesn't require lots of new technology, and it doesn't require a huge amount of new investment.
Merav, is your CCGs going to look at this, or do you have the same system? Or?
We didn't start with such disparate systems actually across our GPs.
You had a better system.
We had a better starting point
Okay.
of people
All right.
using the same.
And it works, they talk to each other?
They do.
Okay. Nick, do you have any questions? Any other questions from? Well, I mean, this is fantastic. Thank you. And again, as Teresa said earlier, you've looked out rather than look up, which is, you just got on and did it. And I wish you the best, and I would love to get more information on this, because integration of care, and more importantly, the enablers, because we actually have a session on this next week. What is it? Estate you mentioned, Daniel, which is very important. Information technology is another very important. I think workforce, flexibility of workforce. So any further information you can send to us will be gratefully received. So thank you for your time, and thank you for all what you do, which is great. Thank you.
Thank you.
So on that note, I just say a few words, say thank you for all the people who participated this morning. I thought there was a very interactive, very rich session. I learned a lot, I'm sure everyone else did, and I think we've captured all this information. We're going to go and dig in a little bit more in some of the areas that did come up during the day, and the different groups. And on that, could I just say, feel free to say a few words if you what went well, what didn't, so I could improve at the next session. And any thoughts on that? Or was it okay?
I think generally it went very well.
Useful?
Yes, very useful.
Yeah.
I thought it was very useful. I thought actually there was a consistency of theme coming through as well, which is very encouraging for the future of the Commission and what recommendations it might make.
And for you, because you're leading
Very
this,
much so, very much so.
this group. Same. Yeah. So could I, on your behalf, thank all the people who were here and took such a significant amount of their time, not just being here, but preparing for it. And thank you on record. And thank you then for taking your time and being here. You've taken a number of tasks being members of the Commission, but at the same time being here part of these interviews. And I'm sure the Mayor would be very pleased that it's gone well. And I have another session like this afternoon, so I'm looking forward to. And, so thank you for your time, and thank you for everyone being here and being so supportive. And anyone watching on the web, any ideas? Jacob.west is the person to email, and please let us know. Thank you.